Welcome to OB Anesthesia Care. My name is Michael Burns. I'm with Webster University in St. Louis, Missouri. This is in preparation for our upcoming Cameroon trip to help increase knowledge of OB anesthesia. We'll see you guys in just a few short days. So basically, regional anesthesia is obviously the most popular method of pain control during labor and delivery. Certainly has minimal depressing effects of the mother and the fetus. The goal is satisfactory analgesia without significant motor blockade. And that is key, where we don't delay second phase of labor, the actual pushing of the infant out. Certainly having intact motor would certainly benefit the fetus and the mother in that scenario. Different type of regional techniques. There's all sorts of, the lumbar epidural analgesia, which is a straight epidural, is probably the most popular. Also combination spinal and epidural, and just spinal anesthesia as well. And that's basically with local anesthesia alone or local anesthetics plus opioid mixture. I would say local anesthetics with opioid mixtures seems to be the most popular in the US. There is also techniques that describe intrathecal opioids alone, as well as epidural opioids alone as well. So epidurals or local anesthetics are most commonly used in the first stage of labor, vaginal delivery, and cesarean delivery. And this is where I'm going to introduce quite a bit of bias, I guess. I believe that when you place an epidural, the primary reason that I place the epidural is that we could go to a cesarean section delivery and it'd be an adequate anesthetic. If you don't trust the epidural to go to a C-section delivery, then you either need to replace it or figure it out. And the second very, very, very good reason to do an epidural is for labor analgesia, because we really want to avoid, and the reason my emphasis on the cesarean is we really want to avoid instrumenting the airway and requiring general anesthesia for the event of an urgent or emergent cesarean delivery. So there's types of anesthetic techniques, if you will. Epidural spinal, combination epidural spinal, we kind of discussed those a little bit earlier. Want to pause a little bit. I know you guys have had an entire series of podcasts about epidurals and labor and OB anesthesia. This is just kind of a summation, but I really want to emphasize the idea of a test dose. Above all, do no harm. So we want the epidural to be satisfactory for labor analgesia. We want it to be satisfactory for the event of an urgent or emergent cesarean delivery. So we must do a test dose. And so that's 3 milliliters of 1.5% lidocaine with 1 to 200,000 epinephrine. And this basically allows us for detection of unintentional intravascular, you have an increase in heart rate, or subarachnoid injection, in which case they would have profound sensory and motor deficits. And basically, the key about a test dose is you're testing where the catheter is not. You're not testing where it's located. You have no idea if it's in the epidural space. You just have some notion that it's not intravascularly and it's not subarachnoid. So make sure you highlight that. And it's best to administer the test dose between contractions. And that's key, because that's going to reduce our false positive signs of intravascular injection, an increase in heart rate that occurs with contractions, right? The other thing is you have to be able to wait. You need to wait 5 minutes after your test dose. Give it some onset time just to make sure this is not time to be in a hurry or to overlook the need of waiting. Because if the signs of intravascular or intrathecal injection are absent, place the patient supine and left tilt position, and you can give now your 10 milliliter bolus of local anesthetic or local anesthetic and opioid mixture. And the idea is that I always say that there's the test dose, and then there's the ongoing test dose, is that you administer the local anesthetic bolus slowly, and you observe for signs that appear to be abnormal, maybe an overly sensory or motor deficit that would alert you that perhaps you're subarachnoid, or you're getting zero effect and possibly it's IV. And so, an epidural that's not functioning, in my professional opinion, is that it is IV until proven otherwise. So while you're administering this bolus, you should monitor the blood pressure every 3 to 5 minutes for 30 minutes until it's stable. If you have an infusion pump, there's all sorts of techniques. You can do a standard 12 milliliter per hour rate, keeping in mind that it's about 1 to 2 mLs per dermatome. You could do programmed intermittent epidural boluses where you administer, 8 to 10 milliliters every 40 minutes. Or if you're in a situation where you don't have pumps for epidurals, you can do intermittent non-programmed, which would be intermittent bolus technique, where we would just administer basically a 10 milliliter bolus every hour to 2 hours when the patient would require that. That is certainly an acceptable technique in the arena of not having an infusion pump. Combination epidural spinal, going to really talk a little briefly about this. This is maybe a technique that may not be available in Cameroon, but certainly in the US, you will see some articles addressing it. The one benefit is that intrathecal drugs provide immediate pain control with minimal side effects. The epidural provides a route of additional analgesia for labor delivery or anesthesia for cesarean. So indications for using a combination epidural spinal would be patients in severe pain. Analgesia or anesthesia just prior to delivery would be another option for that. I would say that if your patient has pregnancy-induced hypertension and you do have like an opioid available, such as fentanyl, I think just doing the combination epidural spinal could be beneficial, because with the subarachnoid portion, you could just give 10 micrograms of fentanyl, provide analgesia, and slowly dose your epidural, where you could decrease the blood pressure to a more appropriate level, but not precipitously decrease the blood pressure with a bolus in a faster manner. So I do think that is a possible indication for that. What about for cesarean? I think that it requires a sensory level of T4. You should preload the patient with either lactated ringers or whatever, normal saline isotonic solution that you have. And basically it's going to require about 500 to 1,000 milliliters. Sorry, I will correct that slide. After injection, the patient is placed in a supine position with left uterine displacement. They're oxygen via mask or nasal cannula. You should monitor the blood pressure every 1 to 2 minutes until stable. And certainly a much more recent recommendation would be to start an infusion of 25 to 50 micrograms per minute of phenylephrine, because we know that hypotension is coming. And I would say majority of OB anesthesia in the US is that we give intermittent boluses of phenylephrine. And so that's implying that you had to wait for the hypotension and then you react to it. We know it's coming, and studies have really had some really nice outcomes if we just did it preemptively before the hypotension actually started. And if phenylephrine is not available, or the idea of avoiding bradycardia is appealing, you can start a norepinephrine infusion at 2.5 to 5 micrograms per minute, or 0.05 to 0.075 micrograms per kilogram per minute. The nice thing about norepinephrine is, while you do get the alpha-1 agonist activity, which is going to raise the blood pressure, with phenylephrine, sometimes you get a compensatory decrease in heart rate, which could be a little bit alarming. The bradycardia can be significant. With the norepinephrine having beta-1 properties, you can see a lot less bradycardia. So now you have a patient with a good blood pressure and a good heart rate. And so norepinephrine could become the medication of choice, but certainly if phenylephrine is not available, norepinephrine is an excellent alternative. Treatment of hypotension could also be with phenylephrine, as we said, intermittent boluses or ephedrine, 5 to 10 milligram boluses. But I really think the infusion portion of this starting it soon, right after the spinal anesthetic is started, seems to be the better way to go. Anesthesia for emergency cesarean. A true emergency requires immediate delivery or urgent delivery. The first question you have to ask yourself, is there time to safely administer a regional anesthetic? Most of our obstetrical colleagues will say, yeah, we have time if it's fast. That's the most, I would say, hands down, the most common answer that I have heard given to me. And you have to ask yourself, is it going to be fast? Do you have the skill? Do you have the experience to do that? Does the patient body habitus and condition conducive for you to administer a regional anesthetic quickly and safely? And those are important questions that you have to ask yourself. Okay, so what about this algorithm? If you do have to go into general anesthesia, I would say, why do we are fearful of general anesthesia and cesareans? Is because of failed airway. And so I think it would be beneficial for us to review this algorithm for safe obstetric general anesthesia. And basically the pre-induction team is you would have a planning and preparation. You have a team discussion, like what are we going to do here? They're going to prep, drape, get everything ready. We are going to pre-oxygenate. We're going to be prepared for a general anesthetic. We're going to have multiple means of direct laryngoscopy. We have supraglottic airway in the room. And we're also going to have, unfortunately, ready to go is a front of the neck access. And so we have to have the entire algorithm present in order for us to safely adventure into the general anesthesia world. So it'd be a rapid sequence induction. If you're consider face mask ventilation, but keep the airway pressure to no more than 20 centimeters of water to decrease the chances of us basically insufflating the GI tract or stomach. Direct laryngoscopy, we should have a maximum of 2 intubation attempts. If you're going to do a third, keeping in mind of time and the condition of your patient, the third attempt should only be done by an experienced colleague. We don't want to keep doing the exact same thing and risk traumatizing the airway, which is going to further decrease our chance of a successful mask ventilation or a successful supraglottic airway device. If you're successful, perfect, proceed with the case. But that's the time to think about how are we going to extubate this patient? How are we going to remove this endotracheal tube? It was difficult to place. Do we have some trauma there? How can we safely get the extubation performed? Now, the second arm of this algorithm is that the obstetrical failed tracheal intubation. So if you try 2 times, maybe a third with an experienced provider, if that fails, you have to declare a failed intubation and call for help. Maintain oxygenation as much as possible with mask ventilation and place a supraglottic airway. We're bringing LMAs with us. We're bringing iGels with us on our trip to see you guys. I'm also bringing a video laryngoscopy and in the form of the glide scope. I would say that intubation at third attempt by an experienced provider, you certainly want to utilize that equipment if it's available to you. So we're going to have a supraglottic device placed, and we want to make sure that we keep that maximum attempts to 2. They're successful, very, very high success rate with the placement of LMAs. But in fact, if it does fail, minimize your attempts to only 2 and also face mask ventilation. If that fails, we have to declare this a can't intubate, can't oxygenate scenario. And at that point, we have escalated this. We have to give 100% oxygen. Make sure you're excluding laryngospasm. And how will you do that? Ensure that you actually have neuromuscular blockade. And then finally, the front access of the neck. And that's where we have a surgical airway, which in this scenario would be a life-saving technique. If that is successful, is essential to safely proceed with this surgical procedure, proceed with surgery, or awaken the patient if it's not essential or safe. Certainly by time the surgical airway would be established, you would proceed with the surgery and think about how you're going to care for this person afterwards. All right, hemorrhage. Hemorrhage is the most common of the severe morbidities complicating obstetrical anesthesia, and certainly one of the highest causes of death of the OB patient. Per 100,000 deliveries, hemorrhage ranks high on that list, the highest. Placenta previa, placenta abruption, placenta, and uterine rupture are the three top hemorrhages in the obstetrical population. So when we think about postpartum hemorrhage, okay, so those are, the patient's bleeding after, with the third stage of labor, you've given some Pitocin, you want to control cord traction, their uterine massage after delivery of the placenta, and there's now some bleeding. So what do? If there's brisk bleeding, falling of the blood pressure, which is postpartum hemorrhage would be defined as greater than 500 milliliters of blood loss. We want 2 large bore IVs. We want oxygen. We want to monitor these patients very closely. The blood pressure, the pulse rate, oxygenation, urine output. And this is going to be a team approach. We're going to have to basically gather a team that's going to care for this patient. We like to call it the 4 T's of postpartum hemorrhage. And this, as the team is gathering, we should think to ourselves, do we have a tone problem? Do we have a trauma problem? Do we have a tissue problem or a thrombin problem? And I think the 4 T's are pretty easy to remember. The tone is, do you have a boggy uterus, right? Did you do bimanual uterine massage? You have oxytocin infusing? Do we need to move on to other medications such as, Methergen or Hemabate? What about trauma? That's where you need to explore the lower genital tract and basically consider exploring the uterus. And do we in fact have a genital tract tear, inversion of the uterus? And so certainly we'd have to examine that patient for this trauma. You would have the suture lacerations, maybe drain hematomas, and replace an inverted uterus. What about tissue? When we think of tissue, we think about inspecting the placenta, and you want to see if there's placenta retained. And that would be a cause for postpartum hemorrhage, and we would have to manually remove with curettage. Methotrexate could also be used for that. Lastly, the last T would be thrombin, and the blood's not clotting. And so at that point, we'd have to replace those factors with fresh frozen plasma or platelet transfusion. If available, some sort of recombinant factor could be entertained. And so we want to, check a CBC for their platelet count. We would want to get some coagulation studies, and we'd also want to type and cross the patient. Now, let's say this postpartum hemorrhage is escalated to blood loss greater than 1 liter or 1.5 liters. Then you would declare that's a massive hemorrhage. And at that point, you would want to transfuse, packed RBCs, platelets, and clotting factors. You would have to support the blood pressure with vasopressors, ICU. You would want to consult the ICU staff, hematology, and surgical consult as well. Think about uterine packing, some sort of tamponade procedure, maybe even some vessel embolization, ligation or compression, sutures. Lastly would be a hysterectomy. Remove the organ that is bleeding. So let's review the 4 T's one more time. They're super important. As someone is bleeding postpartumly, we want to think about tone, trauma, tissue, and thrombin. And if we keep these 4 T's in mind, it'll help us work through the cause or etiology of this postpartum hemorrhage and give it a more appropriate therapy. All right, so what about placenta previa? Incidence is around 0.6%. In the US, placenta may cover the internal cervical os completely, partially, or may close to the internal os with painless vaginal bleeding. And that's probably the key for that, is that there could be a lot of blood in there that just isn't coming out because the os is covered, okay? So what are associated factors? And this is where we get into the differential diagnosis, like what's the likelihood that we're dealing with placenta previa? Did they have previous cesarean sections? The more C-sections they have, higher risk for placenta previa. Have they had any kind of myomectomy of their uterus? Multiparity, advanced maternal age. Those are risk factors for placenta previa. It can be grossly underestimated their blood loss. Again, the blood loss can be as high as 4 to 5 liters, depending on their blood volume, and certainly would not be recognized completely. And the patient's not going to give you symptoms other than hypotension, tachycardia. It's going to be painless vaginal bleeding. They're going to become unstable, but they won't have that pain to maybe would alert you a little sooner that there's problems. Management, immediate cesarean delivery, large IV access, 2 of them, replace the intravascular volume deficits, crystalloids, and blood products if necessary. So about placenta accreta. So placenta accreta is basically the placenta attaches firmly to the uterine wall, as opposed to the normal placental attachment that's separated from the uterine wall by a fibrinous layer. So it's a more firmly attached and again could predispose to some placental and not all of it being removed, so retained placental parts. If you have placenta accreta, that's placenta invades at least halfway through the uterine wall and certainly going to predispose to some increased blood loss as well. Placenta percreta, invasion through the uterine wall and sometimes into nearby tissues like the bladder. And so that could be a very significant cause of hemorrhage in the OB patients. So what's the management of placenta accreta? It could in fact be a cesarean / hysterectomy. If you would like to preserve the uterine conservation, you could have placental removal and oversewing the uterine defect, localized resection and uterine repair, leaving the placenta in situ and treat with antibiotics and removing it later. And so basically stabilize the patient, leave the placenta as is and treat with antibiotics prophylactically and remove it at a later time when the patient is more stable. So again, more risk factors about placenta previa. It basically in a spectrum occurs about 3% of women diagnosed with placenta previa as far as accreta. And that's if they have no prior cesarean deliveries. So if they have a diagnosis of placenta previa, basically about 3% of them are going to have placenta accreta. Placenta previa and 1 or more previous cesarean deliveries, the risk of accreta spectrum is dramatically increased. And so if they have a diagnosis of placenta previa, the risk of placenta accreta is 3, 11, 40, 61, and 67% for the first, second, third, fourth, and fifth or more cesarean deliveries, respectively. That's a big deal. So the more cesarean deliveries with a diagnosis of placenta previa, we're certainly going to be almost surprised by the 4th one if they in fact don't have accreta. So what about placenta abruption or abruptio placentae? Most common cause of intrauterine fetal death. And this is, remember, about 80% of the blood flow to the placenta. And so, again, most common cause of intrapartum fetal death is because lack of blood flow. And this is separation of the placenta. It can be mild or severe. Basically, treatment would be immediate delivery. Unlike previa, this is going to be painful vaginal bleeding with uterine tenderness and contractive pain. So what's the technique for delivery would be regional anesthesia versus general anesthesia. And that's really going to depend on the urgency of delivery and the maternal hemodynamic stability and if they are developing a coagulopathy. So placental abruption is a big cause of intrapartum fetal death. It's certainly going to be painful. It could be on the spectrum of mild to severe. And that's going to dictate if you do a regional anesthetic versus a general anesthetic on this patient population. And really the urgency of the delivery is going to be, again, if it's on the severe side, it's going to be emergent delivery. If it's on the mild side, it's going to be urgent to emergent. Maternal hemodynamic stability, regional anesthesia would be not advantageous in that event. If they're unstable, then we would further decrease their hypotension and decrease their sympathetic tone, and they would become extremely unstable at that point. And we do have to ask ourselves, are we dealing with a coagulopathy type scenario where they're losing mass amount of blood products, including their coagulation proteins. Uterine rupture incidence is about 1 out of 1,000 to 3,000 deliveries. Can occur during labor. Dehiscence of the scar from a previous cesarean could certainly be a predisposing factor. Intrauterine manipulation forceps could cause uterine rupture, and it could be spontaneous rupture following prolonged, intense labor. The symptoms basically have frank hemorrhage, fetal distress, loss of uterine tone, and basically a continuous abdominal pain and hypotension, even in an epidural. So I would say my experience, I've had about 3 uterine ruptures in my career. Every single one of them, it was a call for the blood pressure is low and she's hurting. Your epidural, can you come check that? So anesthesia commonly is the folks that's called first. And when I looked at the monitoring the patient, what I noted was a previously well-functioning epidural that now wasn't, because the patient was having like breakthrough pain. The second is that the fetus tracing looked terrible. They had some hypotension. That triad led me to, do you have an abruption? Do you have a uterine rupture? I did not know either one, but I did know that we definitely had a uterine / placental problem. Our obstetrical colleagues were notified, emergency delivery, and was performed with hysterectomy as well. So what's the treatment? C-section, cesarean delivery, volume resuscitation aggressively, and the possibility of a hysterectomy if a repair is not possible. I think of my 3, I think 2 of them ended up a hysterectomy and 1 of them was a repair. So certainly want to be prepared for that when you're just initiating your anesthesia care of obstetrical patient. You have to plan for all of these scenarios to occur. All right, so what about premature rupture of membranes, chorioamnionitis? Basically infection of chorionic or amniotic membranes. They may be involved in the placenta, uterus, or fetus. One of the predisposing factors of that would be basically premature rupture of membranes and or prolonged rupture of membranes, either recognized or unrecognized. Maybe the mom did not know that her membranes ruptured. Maybe they've been in their care for a long period of time with ruptured membranes, and that would certainly put them at risk for some sort of infection. Maternal complications would be intra-abdominal infection. Worse than that yet would be septicemia, where now they have frank signs of sepsis. It's also noted that if it's infected, acidotic environment, the muscle's not going to contract very well. And so you'll probably end up with a postpartum hemorrhage type scenario as well. The fetus has a number of complications related to that as well: acidosis, hypoxia, and also septicemia as well, and developing frank sepsis. So bad scenario for mom and bad scenario for the fetus as well. More on chorioamnionitis is that the diagnosis, fever greater than 38 degrees Celsius, maternal and fetal tachycardia, uterine tenderness, and a foul smelling amniotic fluid, and their white count is markedly elevated. So leukocyte counts up, they have a fever, uterine tenderness, tachycardia by both mom and fetus, and a foul smelling amniotic fluid could lead us to this diagnosis of chorioamnionitis. Anesthesia. It's pretty controversial as far as, do you do a epidural? Can you still safely do a regional anesthetic? I would say lots of controversy with the fact that they do in fact have an infection, but is it localized enough to safely perform a regional anesthetic? One of the things that is going to tower over that discussion is, what's the hemodynamic stability of the mom? Is she frankly septic? Is she coagulopathic, or platelet count starting to drop? So, if they have signs of septicemia, thrombocytopenia, any sort of coagulopathy, then the regional anesthetic would not be advantageous. And so most of the obstetrical colleagues in the United States would say if those are not present, then it's probably okay to do a regional anesthetic. Again, because of the advantage of avoiding instrumenting the airway and the complications that come with that. So what about pregnancy-induced hypertension? Certainly ranks up on the list of causes of problems for moms during the delivery. Ranks high, probably second to hemorrhage as far as causes of maternal mortality with delivery. It's defined as a systolic blood pressure greater than 140 and a diastolic greater than 90 millimeters of mercury, or a consistent increase systolic blood pressure of 30 millimeters of mercury, or a diastolic pressure by 15 above their baseline. So, we want to make sure that we have to make sure we want to accurately describe one of the three syndromes. Is it preeclampsia, eclampsia, and HELP syndrome? Those are the consequences that we think of with pregnancy-induced hypertension. Will this in fact lead to eclampsia, or and further to HELP syndrome? So pregnancy-induced hypertension definitions that we said before, basically the triad of symptoms occurring after 20 weeks gestation and resolving about 48 hours after delivery. So delivery is a curative treatment in most cases. I would say also the triad is that they have blood pressure parameters as we described before. Do they have protein of greater than 300 milligrams per deciliter? And do they have edema of the hand and face? So do they have edema? Do they have proteinuria? And do they have blood pressure markers? If all that lines up, they have pregnancy-induced hypertension. What's the definition of eclampsia? Let's say now this keeps, without treatments, progressing to eclampsia. It still has the above criteria. They still have blood pressure problems that are elevated. They have protein in the urine, and they also have edema, but now they have the onset of seizures. And now that patient is eclamptic. Can pregnancy-induced hypertension progress to HELP syndrome? And we think about HELP being hemolysis, elevated liver enzymes, and low platelet count. And we can see how, are we going to end up with a fractured liver? Are we going to end up with, consumption coagulopathy from the hemolysis and anemia? Are we going to end up with more bleeding related issues with low platelet count? And so HELP syndrome, we should monitor for that and try to prevent pregnancy-induced eclampsia or PIH, pregnancy-induced hypertension, from progressing to eclampsia and HELP syndrome. Some of the complications of pregnancy-induced hypertension: neurologic. You have to ask, do you have a headache? Do you have visual disturbances, hyperexcitability, and maybe leading to seizures? The pulmonary consequences is what we fear with our general anesthesia related world, is that do they in fact have not just edema of their face and hands, but do they have upper airway edema, which is going to make general anesthesia very difficult as far as a successful intubation. And do they also have risk factors of pulmonary edema? Cardiovascularly, their hypertension is going to basically result in intravascular volume depletion and an increase in systemic vascular resistance. And that's why the regional anesthesia can be a little tricky in this patient population, because they're going to be intravascularly depleted, even though they're extremely hypertensive. So we could have a very fast, precipitous decrease in blood pressure. Hepatic, they could have impaired functions, elevated enzymes. We'd have to watch out for that. Renally, again, we talked about the protein in the urine, retained sodium retention. So basically, we could get some edema with that. Hematologically, they could have a low platelet count and a prolonged PTT. Again, thinking of having some coagulation issues, thrombocytopenia, and a prolonged PTT. So what's the treatment? Bed rest. Antihypertensive drugs, labetalol, hydralazine are good options for that. Magnesium sulfate infusions or drips, 4 to 6 milliequivalents per DL are therapeutic levels. Basically, if we're using magnesium sulfate, we should keep in mind that we'll potentiate a non-depolarizing muscle relaxants. So we'll get a little more muscle relaxation for a prolonged period than we would initially plan for. Again, when we intubate, we have to think about when we're going to extubate and how can we do that safely. So that would be part of that conversation. Anesthesia, epidural in the absence of coagulopathies, which means their platelet count is greater than 85,000. It's a nice treatment for PIH. And that's why, why are we traveling to Cameroon to even discuss epidurals, is to help out avoid general anesthesia, maybe have some control of pregnancy-induced hypertension, which ranks up there fairly high as far as the causes of maternal mortality, and also allow for more complete delivery, and if you need to do any extraction of placental retained parts and so forth. Another treatment for PIH, as we said with epidurals, fluids. Be careful giving a lot of crystalloids. This is where we're going to get to. We have to be a little more cautious with that, judicious with our crystalloid administration. Again, they're edematous, they're hypertensive. We don't want to make that scenario worse. Certainly, they're predisposed to pulmonary edema already. Colloid in this scenario may be a better choice. We would give 250 to 500 milliliters, something that's going to stay in the intravascular space a little longer, versus crystalloid is going to just kind of worsen our extracellular component or interstitial type edema, and that would not be advantageous for us or the patient. What about this anaphylactoid syndrome of pregnancy, amniotic fluid embolus? It's pretty rare, about 1 out of 20,000 deliveries, but it does have a very high mortality rate of about 86%. So basically, it's entry of amniotic fluid into the maternal circulation. If there are any breaks in the uteroplacental circulation, it can happen during delivery, during labor, during cesarean delivery. It can also happen even postpartumly. The presentation is basically of cardiac arrest type scenario. We have sudden tachypnea or shortness of breath, maybe cyanotic or hypoxic, and they're basically going to be pretty shocky, hypotensive, and generalized bleeding because of DIC and cardiovascular collapse. So very unstable and roughly pretty quick. Treatment is basically aggressive cardiopulmonary resuscitation. I did want to bring in this idea of the AOK protocol. It's certainly experimental in the US, but I thought it'd be noteworthy to mention that if you in fact think you have amniotic fluid embolus, maybe initiating the AOK protocol and along with your other resuscitative measures would be beneficial. And then basically the A stands for atropine 1 milligram, ondansetron as Zofran 4 milligrams, and ketorolac 30 milligrams IV. When we think of someone who cardiac arrest in the postpartum period or any time during the maternal care, we kind of have to rule out 3 major categories. Is there an anesthetic related cause? Do we have a high or total regional anesthesia block? Do we have local anesthetic systemic toxicity? Do we have a pulmonary aspiration of gastric contents? The other category would be pregnancy related. Do we have uterine rupture, uterine atony, placental abruption? Do we have acute severe bleeding, peripartum cardiomyopathy, or do we have eclampsia? We also should entertain the other causes of cardiac arrest that's maybe not as OB related, but certainly air embolus could occur. Pulmonary embolus could occur. They also could be a little hypercoagulative. So it's certainly a risk factor of, DVT progressing to a pulmonary embolus. Sepsis, anaphylaxis, they have some sort of arrhythmia. Are they having a heart attack? Are they having a transfusion reaction? Or are they having a cerebrovascular accident or stroke? And so when we rule that, when you think about someone with cardiac arrest suddenly during, labor or a cesarean or postpartumly, we have to rule out all these other causes too. And certainly why the AOK protocols increased in popularity is because it's fairly benign treatments. The atropine, ondansetron, and ketorolac, if those medications are available to you, it wouldn't be a bad idea to administer those and as quickly as possible, see if you can get some reversal of this this cycle, if you will, that's going to occur with amniotic fluid embolus. And so ketorolac can help you with your thromboxane. Again, that's going to be your pulmonary vascular vasoconstrictor. And that's how they kind of present. If you're looking at echo, they're going to have a high right ventricular pressure. If you have the dansitron portion, it's going to help out with that as far as the serotonin receptor blockade. And certainly the atropine is going to help out with, bradycardia and some of the peripheral vasodilation. So you have atropine is going to help out with our vagal reflex, where you won't be as bradycardic, and a dansitron and ketorolac is going to help out the idea of having pulmonary vasoconstriction and peripheral vasodilation. So multi-gestations, it's a real caution with spinal and vessel compression. And so again, if you're having twin deliveries or more, if you're when you do spinal anesthesia, be mindful of vessels, the vena cava syndrome, if you will. When you position it supine, make sure you have really good uterine displacement. You would likely have an additional IV. Bleeding risk during and post-delivery is elevated, and also uterine atony. So we get to the tone portion of it, of cause of uterine bleeding postpartumly. This portion, we're going to talk about fetal heart rate monitoring, basically just a basic overview of that. So accelerations is an increase of about 15 beats per minute from baseline, and it's lasting more than 15 seconds. Periodic accelerations reflect normal fetal oxygenation, and they're basically very reassuring. The reason why they may be periods of no accelerations, let's say they're less than 32 weeks gestation, maybe some medications, and or the sleep cycle of the fetus, okay? Absence of both baseline variability, though, and accelerations is non-reassuring. Variability is key with fetal tracings. You should have variability. When you lack variability and accelerations, that is a non-reassuring tracing. So it's an important sign of potential fetal compromise. What about decelerations? There's really basically three major categories that we're going to discuss. With decelerations, it's early, late, and variable. So about early deceleration, it's usually about 10 to 40 beats per minute below baseline that mirror a contraction. And so it's not associated with fetal distress. It's probably a vagal response to compression of the fetal head against the cervix. And so as you can see, it's basically a direct mirror of the uterine contractions with uterine monitoring. Late deceleration, on the other hand, is basically a decrease of the baseline following the peak of a contraction. And so you see the peak of the contraction, and then later it's followed by a deceleration. It can be as few as 5 beats per minute from baseline. Late decelerations has a little bit of a more concern for us, more than a little. We have to think about, what is the cause of this late deceleration? Is it maternal hypotension? Certainly, if you're using epidurals, it could in fact be in that scenario. Do you have a cord compression problem? Okay. And so late decelerations with normal variability following acute insults can be generally corrected. It's the late decelerations with decreased variability that is a much more ominous sign, and sign that you're having some fetal asphyxia or compromise. So if you have a late deceleration, we should think, okay, do we have uteroplacental insufficiency causing fetal compromise? That might be us, right? That we are the patient's hypotensive, and at that point, we'd want to correct that. Or maybe they had some sort of insult, cord compression, you reposition, things get better. But if you lose variability, that's going to be a problem. That's the ominous sign. You probably are having some fetal end organ damage. What about variability decelerations? These are the most common. They're variable in onset, duration, and magnitude. They usually abrupt in onset, and that's related to umbilical cord compression. Okay. And you can see there's no distinct pattern. It's either sometimes it's early, sometimes it's late, and sometimes it's really late. And so it has lots of variability. The other key is to check for the fetal variability within the tracing. And in this tracing, you can see there's lots of variability. It looks very nice. So what do you do for treatment of deceleration patterns? Okay, so aggressive treatment to prevent permanent neurologic damage. You should change the position of the mom. You should give oxygen, IV fluids, medications to correct any sort of hypotension. We should think about maybe decreasing the amount of contractions. So that would be an oxytocin infusion corrected, and possibly a surgical or cesarean delivery. So interventions are directed at restoring an adequate uteroplacental circulation. So why do we change their position? Make sure we don't have aortocaval compression. If we maternal hypotension and hypoxia, we treat that with supplemental oxygen, IV fluids, and medications to correct the blood pressure if necessary. And why do we decrease our oxytocin or turn it off? Would be to decrease the excessive contractions. And then if those interventions aren't working and we still have poor tracings, we have to go to emergency cesarean delivery. Well, APGAR scores, we use these with basically assessing how well the fetus is doing right at delivery and a few minutes afterwards. And so we look at the heart rate, respiratory rate, muscle tone, reflexes, and color. And so obviously the higher the score, the more likely the infant's going to do better in the immediate post-delivery period. And really the big one is they're all important, but we look at the heart rate as far as less than 100 or greater than 100, and respiratory effort. Is it slow and irregular, or is it good? They're crying. Everyone loves to hear a crying baby right after delivery. Muscle tone, is it flaccid versus active? Are they crying again with the reflexes? And their color. I would say that's probably the most common place that you'll see a decrease in APGAR score is probably from color. The body's pink, but the extremities are blue. Ideally, we'd love for them all to be, pink and ready to go. But certainly, we should assess for that. And the heart rate and crying and active, those are all reassuring signs that things are going well. Part of our presentations in person for the workshop, as well as the hospitals, we're going to look at and present the Stanford Emergency Manual for Obstetrical Anesthesia. And I have a printout that I'm going to bring with me. We're going to make copies of it when we get to Cameroon and hand these out as well. I encourage everyone to read through it. There's an app. We'll get to that in a minute. But I think that cognitive aids are just life-saving. I mean, I use them all the time. I do a lot of regional anesthesia, and certainly I use, when we think about local anesthetic systemic toxicity, it's nice to have a cognitive aid just to make sure that we're, following the sequence and we're assessing appropriately. And so they address, maternal cardiac arrest, amniotic fluid embolus, anaphylaxis, bronchospasms, anything from depressed level of consciousness, hypotension and bleeding, all the way down to how to care for a stat cesarean or emergent cesarean, transfusion reactions, delivery of twins, uterine atony problems, inversion. More specific to anesthesia, they talk about failed epidural techniques, general anesthesia for cesarean, maternal intubation, and anesthesia for kind of like version, if you have breech presentation, and basically just troubleshooting labor epidural. So I think it's an excellent manual. I got online, submitted our stuff. They, basically described that we're going to Cameroon, and they are so generous, and they allow us to download this stuff, and we're going to bring it to you guys in a few days. So I just want to introduce that. These are the website links for the Stanford cognitive aid groups. They have, a lab for us, a simulation lab, and also download the Stanford Emergency Manual. So if you want to download it to your institution or any kind of mobile device that you can have readily available, a lot of the critical care cognitive aids that we have, we even laminated them and put them in each operating room. Certainly, I find them to be, just God said, it's great. to have some aid to look at when you're dealing with a crisis situation. So we'll be visiting that when we're a little more in person, but I'm going to post this on our WeNAP website and also give you access to obtaining this information. Okay, well, this concludes our OB anesthesia podcast for today. Again, I hope this is helpful, and I look forward to seeing you guys in person over the next 2 weeks, and hopefully we can learn from each other. I'm certainly hopeful that I will likely learn more than I could teach. That seems to be the theme every day. I've been an instructor for probably 12 years, and I learn more from my students than they probably learn from me. And I'm very excited to meet you guys and go over some of this OB related anesthesia techniques and airway management. And have a great day, and I'll see you guys soon.